out of it if you actually... That was kind of important.
I got to see my first complete heart block.
See your first what?
Heart block.
Oh, that's cool.
I hadn't seen one before.
Something important are the 5 factors that affect respiration are ventilation, distribution, diffusions, perfusion, and circulation. All the respiratory disorders have something that affects one of those 5 characteristics. The rest of this you can read about, honestly. Pictures, labs. Dosages for the drugs are in here. Ventilation. Yeah, let's just start here. Let's skip the whole first thing. Does that sound good to you?
Works for me.
People at home, you're adults, please read it yourself. I'm not reading it to you tonight. I'm tired. I'm tired. That's what I said.
Heard.
I know, I'm tired, and I really feel like it's not going to sink in with me just reading to a blank screen.
This is not a pocket model, I swear.
So, the reason they say that the reason you're more likely to intubate on the right side is because that side's straighter, and it's more in line with the trachea than that left because it makes that sharp L. So that's a fun fact. Those 5 factors I listed out a minute ago is the second fun fact. And you ever hear about shunting?
Mm-hmm.
Shunting's when blood goes back into circulation without being oxygenated. And shunting is the only cause of hypoxemia that cannot be fixed with 100% oxygen. Because the air is going into the lungs, but it's not going to functioning alveoli. So just because you're putting in 100% O2, it doesn't mean it's going to the functioning alveoli. It's still not getting to where it needs to be. So, fun fact. It doesn't actually come into contact with them, so that's the fun fact for that. This is really important in the test, and it asks a billion questions about the oxygen hemoglobin affinity curve. And it's the stupidest, it's one picture, but it's like 15 questions in this book. And it drives me nuts. So basically, it's about when the curve starts to shift, whether it has a higher affinity for the oxygen and the hemoglobin, whether they like each other and they don't want to let go, or a leftward shift where they stop liking each other as much and they let go too quickly and they offload too quickly. And that's all it is. Like, legit. But they make a big deal out of this. So a shift to the left is an affinity of the oxygen and hemoglobin being increased. Comes from alkalosis, hypocapnia, hypothermia, and this special decreased enzyme when you have massive transfusions. So, that's what a left shift is. It's where the oxygen, it comes off too fast. No, and it doesn't come off fast enough, I'm sorry. An increased affinity, meaning it binds to it and doesn't want to let go. It's like, no, you mine. A decreased affinity is a shift to the right, and it causes it to dissociate more rapidly, like in acidosis, hypercapnia, and hyperthermia. I think I said that right. It's been a really long day, but it's all on the slides. They make a really big deal about this. So right dissociates more quickly, left says, hell no, you mine, I'm sticking with you. Make sense? They make a huge deal out of this one chart, people at home. And it's like 15 questions in this book, Andy. And it's not fair because it's one picture on one page in the corner. But it's this huge thing. And all the books make a huge deal out about it. But that's what it is. Ta-da. Next slide is ARDS. ARDS is the most... It is defined, and it's in bold because it's test questions, again. It's a PO2 of less than 60 and a PaCO2 from 45 to 65. Most commonly caused by sepsis. A lot of our trach patients and common vent patients. The chest x-ray, this is where it becomes part of the test question stuff, is the PO, the lab numbers are a test question, and when it'll give you a chest x-ray in the questions. Widespread pulmonary infiltrates indicates ARDS. How we fix it is we add PEEP. That's it. That's the only thing we really could do, is we add PEEP. And note that the longer you have the lungs at a higher PEEP, the less compliant they become. And then you have to add more PEEP, and then they become less compliant, and then you have to add more PEEP, and you can end up with really high levels of PEEP. And you don't take them in the air. It's bad juju. I put the pathophys in the slides. People at home, you can read the slide notes, and there's pathophysiology exactly about how stage 1 is a pro-inflammatory response, and stage 2 is pulmonary fibrosis. Read it on your own time. COPD is not a condition, it's a classification of conditions to include asthma, chronic bronchitis, and emphysema. Just saying. Asthma is on one end of the spectrum. It's an obstructive pulmonary disorder caused by reversible airway obstruction due to increased responsiveness to various stimuli. You control it with a long-acting. You fix it with a short-acting. The way it works is listed in the pathophys behind it, in the slide notes. Basically, the airway becomes hyperactive, and the smooth muscles contract when they come into contact with the stimulants, and then you give the beta agonist to relax them. That's all it really is. I mean, there's more to it, like the cellular infiltration and the mucus edema can be seen. Then you also have diminished secretion clearance because of the contraction and because of the increased secretions. And you can also get a hyperinflation of the lungs. You'll see a prolonged expiratory phase with these guys because you can get the air in, but it's harder to get the air out because of the constriction. That's one way that I was told to tell between a laryngospasm and a bronchospasm. Laryngospasms, they feel like they can't get air in. Bronchospasms, they feel like they can't get air out. And an absence of wheezing is really bad. Really bad. Because it means they're not ventilating well enough to even wheeze and make the airway sound. Chronic bronchitis is the mucus cells in the bronchioles. They have a party and they start throwing out all these copious secretions that gets into the airway, gets infected. It gets into the airway and it makes it so the alveoli can't inflate properly and the patient's not able to ventilate. They call them blue bloaters. Bronchitis blue bloaters. I think that's a cute little saying. And I did it in word art too. Just for the fun of it. Emphysema is the pink puffers.
She made them blue.
Yeah, that one's in blue still. I couldn't figure out how to change the color. Google Slides is different than PowerPoint. There is a lot of notes on emphysema I took. I was really into this for some reason. Basically the alveoli are destroyed, and so are the supporting structures. So the airspace around the non-respiratory bronchioles starts to get bigger. And air becomes trapped into the lungs, but it's not actually becoming exchanged. Breath sounds and heart sounds can become muffled because of the increased diameter of the thoracic cavity of the air getting trapped in there. Patients will have respiratory acidosis with a metabolic alkalosis. It's a common finding. This is where the chest x-ray shows. Chest x-ray for this one would be hyperinflation of the lungs, narrow and elongated heart, and a flattened hemidiaphragm. That's it. The only thing you can see in the field, you might see low voltage because of the bigger size of the chest. P waves and inferior leads and right axis deviation because of the elongated heart, maybe. But that's about all you can see in the field. So the only treatment that we do for it is the same, just beta agonist and continue with fluids. So that's it. Hey, did you know that gases expand at higher altitudes? Did you know it's a really bad idea to take patients up in the air with pneumothoraxes unless they already have a chest tube where you can place one really quickly? Very bad. Don't do it. Don't take them up in the air unless you have a way to fix it. Spontaneous pneumos occur when a bleb, which is that little, how did I call it? A subpleural bleb. I can't talk, I'm sorry. It's a little spot on the top of the lung. This is where it's commonly found, and it kind of causes a spontaneous pneumo. I think I have one more slide. I have two. PE. This slide back and forth thing is kind of fun, actually. I'm just gonna say. So the clot gets formed due to poor circulation, blood pooling, many different reasons. Hypercoagulative state. Once the clots form, the lysis system in the body has trouble naturally breaking it down. That's why we have all these thinners and antiplatelet aggregators and blood clot, like the ACEs, like the streptonase, kinase, and all those good things. So we have those. The body's not that great at breaking up clots. So it goes through the venous system, into the right heart, into the pulmonary vasculature, and then turns into a PE. And that's it. That's PE. Pneumonia is like 6 pages in the book, and it lists out like all these different kinds. Really cool because like each different kind is caused by something different. So like I figured out the other day that I had a patient with like a streptococcal pneumonia based on the fact that he, what was that I had used? Which evidence? I think it was based on the fact that I think he had an infection more thing going on. He didn't really aspirate. He didn't have any kind of masses or anything in his chest that we know of. So, I mean, the treatment is always the same. It's just a cool fun fact. They're always treated with antibiotics, fluids, and oxygen. And that's it. We knocked it out in 15 minutes.
Yay.
I didn't feel like reading all that stuff because we're adults, we should be able to read. I can put my laptop. Ooh. And that should shift, yeah. Yeah. I'll email it out to you, and it'll have everything in it. This is like a really dense chapter just because it's a lot of technical stuff, but it's technical stuff that we already know. Or like you should know. As a medic, you should know these things. Like, you should know, we'll pull out an example. You should know the definitions of apnea, bradypnea, and tachypnea. That was like a whole page. You should know that BLS comes before ALS. You should know the process of intubation. The drugs are new for a couple of them, but not all of them. But they're in there. And then the vent stuff will be separate. We have an RT coming in to teach the actual vent thing. And she's pretty cool. So we're not going to even touch on vents. But the first part of this does go over and in the PowerPoint. So it's in there for those that want it. Yeah. I made a game.
What you make?
I made a matching game on the board.
Oh.
Yeah. So... And I prepared 2 scenarios, but it's just me and you. So,
Sorry.
That's okay. Thank you for coming.
Mm-hmm.
We can skip the scenarios if you want. Or I can talk you through them. I don't really care.
Let's skip.
Okay, we can skip. Because there's nobody here to work with you. And it's no fun. So tonight was a very short video, people at home. Everything's online. And I'm working on drug cards for everybody so that we can have them for the RSI drugs. I don't remember the topic for next week off the top of my head, but everything will be uploaded soon. So, I'm tired. Night, people.